Yeah, it's interesting. So cytogenetics is playing a smaller and smaller role as we learn more and more about the molecular genetics of AML, because there's a large group of patients who either have a normal karyotype or an uninformative karyotype. And there are certain genotypes that are strongly predictive of long-term response and survival after chemotherapy, core binding factor rearrangements being some of the stronger favorable prognostic markers, and monosomal karyotype or complex karyotype being generally associated with very poor outcomes, and certain balanced translocations also generally doing relatively poorly in version 3, the KMT2A rearrangements. So with those patients, we can use genetics when they have recurrent abnormalities that we know this is very predictive of how patients will do. The challenge, though, is that more and more there are patients who they don't have an informative karyotype, but they have mutations that we know can either positively or negatively impact their outcome. And the ELN 2022 update that just came out has increasingly used molecular predictors of outcome from next generation sequencing. I think we have to sequence like 13 different genes to adequately risk stratify patients based on that classification. So we haven't learned a lot new about how karyotype predicts long-term outcome, but we're getting better at refining prognosis from gene mutations.